Good morning, everyone. I'm going to introduce our speaker. We have Dr. Scott Roberts. He is Assistant Professor of Infectious Disease and Associate Medical Director of Infection Prevention at Yale New Haven Hospital. He will be giving a lecture on bloodborne pathogens. And just to give some background on Dr. Roberts, went to Albert Einstein College of Medicine for medical school, did a residency in internal medicine at University of Michigan in Ann Arbor, and then a fellowship in infectious disease at Northwestern Memorial Hospital. He then started here at Yale in July 2020, helping manage the COVID response and serving as medical director for infection prevention. So obviously very important, and we appreciate him giving us this talk. So I'll turn it over to him.
Thank you. Thanks, everyone. So I'll be talking to you guys today about bloodborne pathogens and really some observations that studies have shown about surgical residents throughout their career in terms of bloodborne pathogen risk from needle stick exposure, and then some strategies about what we do at Yale, and then infectious disease management strategies about if bloodborne pathogen needle stick exposures do occur. I currently serve in half my role as the Associate Medical Director for Infection Prevention at the hospital. So if anybody has any infectious disease related concerns while you are out in the hospital, in the operating rooms, you get splashed by something, you don't know what it is, you think you got exposed to TB, our team is here really 24/7 to help you guys. So feel free to reach out. I'll put our department's number at the end of this slide. And then I'll also preface by saying there are two Scott Robertses at Yale. So if you're trying to reach me, you need middle initial, which I should put it up here, but it's Scott.C.Roberts. Scott Roberts is in GI, and there's a lot of crossover, and we know it, so we forward each other stuff. But so I have no disclosures, and my goal today is really to help you understand how transmission occurs, what the major pathogens are and our management strategies, and then what you guys can do to protect yourselves in the workplace. And why are you here? This training and this lecture, not necessarily this lecture, but this training of bloodborne pathogen is mandated by OSHA as surgeons. So all employees with occupational exposure must receive annual training on the hazards associated with blood and other potentially infectious material, and also how you can protect yourselves about it. And there hasn't been any fundamental or major change in our policy or literature that have come out since, if anybody attended this lecture last year. So what are bloodborne pathogens? They are infectious agents present in the blood or body fluid of individuals that can be passed from one person to another. We classically think of these as three viruses: HIV, Hep B, and Hep C. However, really anything can be transmitted through the blood. So if somebody has, malaria, for instance, and they have a positive parasitemia smear, and you sustain a needle stick exposure, our team would evaluate that and with occupational health to see, what is your risk for malaria? Do you need to go on anti-malarial prophylaxis? So a lot of times we really focus on the key viruses that we have management strategies for, but there have been case reports of multiple things being transmitted to healthcare workers through bloodborne pathogen exposure. Relevantly, there are now a number of healthcare workers who got bloodborne pathogen transmission from Mpox or monkeypox with the most recent outbreak, in a number of needle stick exposure events from people drawing blood or trying to do biopsies on the lesions. But not just blood is infectious, lots of body fluids are infectious. And so Yale actually says any body fluid other than sweat, if you get exposed, we should do an evaluation for a pathogen transmission. So we certainly see people in the dental clinic, for instance, who get splashed during some sort of drilling of a tooth, and maybe they get something in their eye. And so that would be a body fluid exposure. And we would really want to treat that as seriously as we do a needle stick exposure. These are the three viruses that we get most concerned about: hepatitis B virus, Hep C virus, and then HIV. Hep C is the most common in the United States, and it's estimated that about 1 to 2 people in the United States out of 100 have one of these three viruses. So particularly relevant for you guys if you see a trauma case and you have no idea the history of the patient, or they're found down We essentially practice what we call standard precautions, which we'll talk about, but it's treating that patient as if they do have one of these viruses, since we don't know. Exposure does not always lead to infection. It really depends on a number of factors: the number of organisms of the virus that enter the blood, the infectious characteristics of the agent, how virulent is it, and then the health status of the exposed individual. If I'm Hep B vaccinated and I get a needle stick, I really have no concern. But if I'm Hep B naive, obviously that's a very different scenario. And in terms of risk, these three viruses are not created equal. If I had a patient with all three viruses, I am most likely to get hepatitis B. There's about a 30% chance of that Hep B being transmitted if I'm unvaccinated and naive. Hep C, it's about 1 in 30, so about 3%. And then HIV, a lot of people are most concerned about HIV. That's actually by far the lowest risk. It's about 0.3%. So if somebody is active HIV viremia and you get a needle stick, the odds are you will not get a transmission event there. There's 3 routes of exposure, and the bulk of my talk today is going to be focused on the first one. So skin puncture with contaminated objects as the most important, but also splashes to broken or non-intact skin, and then splashes to contact with the eyes, nose, or mouth, or mucous membranes. And having dealt with a lot of these, these are quite emotionally complex events. Certainly I've sustained my fair share of needle stick exposures, fumbling over, central line insertions as an IM resident. But one of these happened in the middle of the night, and I was trying to do a central line on my own and got a needle stick exposure from an outside hospital transfer. I had no idea what the patient had, if they had Hep B, HIV. And I was extremely anxious about it. I didn't sleep well that night. I was like, what do I do? Unfortunately, I end up talking to OC Health. They tested the patient, they were negative. But I very much sympathize with the fact that, these can be very burdensome events emotionally. Half of people have anxiety. There's a lot of self-blame, abandonment. Some people have reconsidered their career choices, especially if this happens early in training or medical school. And this distress often extends to family members. And I'm going to state this now and then once more at the end, but what do you do? If you sustain a needle stick, the first thing is you disengage from the operating room table or the patient interaction in a safe manner. Really, the goal of that is to avoid getting a repeat needle stick exposure if there's an open needle out. Wash the area with soap and water, soap being the disinfectant. Report this to occupational health. And I believe this is old with saying the ED is after hours. I believe they have a 24/7 line that you should be able to contact. We in infection prevention certainly do. And if you contact us on mobile heartbeat, somebody should get back to you really within 5 minutes. Make your supervisor aware. Some facilities have the supervisor escort that person directly to occupational health right there. Occupational health, in conjunction with our team, will do a confidential medical evaluation, really to see what happened, what was the issue with the device, or was there a safety feature that didn't work, what PPE was used, and then the source info. So if the source tests negative for everything, usually we're done. There's not much that we need to do. But if we don't know, we have to arrange testing of the source, or if they have malaria, for instance, how do we manage that? And then if indicated, we'll perform lab testing in both the person who got stuck for baseline testing, if we don't have it already, and the source patient as well. And then depending on the scenario, other blood tests as well. And then in scenarios where there is risk of some sort of HIV, Hep B, Hep C transmission, we can do post-exposure prophylaxis, Hep B vaccination, Hep B immune globulin in those who would qualify. And then we do post-exposure counseling and follow-up. And before I get into really the brunt of the talk, I'm just going to do a quick aside on why we offer HIV therapy right away. And it's the problem is that HIV is in the dendritic antigen presenting cells within 24 hours after being exposed. This then brings it to the CD4 T lymphocytes, which bring it to the regional lymph nodes really by 24 to 48 hours. Some patients can have HIV viremia within 5 days of a needle stick. And really the goal of post-exposure prophylaxis is it blocks that infection of the CD4 T cell. And the earlier you give it, the better. So the sooner we know about it and can start this, really the better the odds that there will not be a transmission event. There have been 21 worldwide cases of failure in those who were exposed to HIV and were put on post-exposure prophylaxis and ended up getting HIV. 16 of these were, I believe, in zidovudine monotherapy, which is really not done anymore. And that was actually the first antiretroviral medication available. But 5 cases have occurred in those who have been on more modern combination therapy. In these patients, they really had no delay in time to seroconversion, and there were no adverse events at the end of the day. But why they failed, it was a little bit unclear. The study hypothesized delays in treatment for some. The dose was too low. Perhaps the virus was resistant. There was a high inoculum exposure, so a high burden of HIV viremia. And then treatment duration was too short. The incubation period for a lot of these viruses can be weeks to months. Hep B, the incubation period is usually 90 days, but it can be up to 6 months. So we usually do 6-month follow-up testing. And then what's your risk of HIV? Note needle stick there is 4. It's 0.3%, so very low, especially when you compare it to transfusion, which is 95%, and then perinatal transmission or vertical transmission is really the second highest. And then you can see IV drug use 0.6, and then sexual transmission of HIV is actually in somebody who has active HIV viremia is still relatively rare per occurrence, but over repeated time, obviously there's higher risk of exposure or transmission. Many states have laws allowing us to test the source patients. HIV is one of the few lab tests that patients must consent to receiving it. Most patients willingly consent, but the testing can be performed in an anonymous, confidential manner. And I'll tell you, I ran into trouble with one patient whose wife was in the room and did not know about the husband's HIV status. And the husband refused us telling the wife. And so what we had to do was we had to talk to the state health department, who anonymously called the wife and said, at some point in your life, you've been exposed to somebody with HIV. We recommend you get a test. And so there's a lot of laws behind HIV, but if it happens and the patient refuses, we still have a mechanism at Yale to really perform this in an anonymous and confidential manner so the patient will not know, but the healthcare worker will, because this will guide our management strategies. And if somebody gets exposed, we don't know anything about the patient, we would recommend an HIV antibody and antigen test, a Hep C antibody test, and then there's a whole bunch of Hep B studies, which I'm sure you all have dealt with, but the key one is the Hep B surface antigen. And this is the actual replicating Hep B virus in the blood. So if that's positive, they have active Hep B. The core IgM is usually an antibody in early disease, and the core total is the antibody that you've seen Hep B at some point in your life ever. So we see a lot of patients who are just core antibody positive, and oftentimes that's infection from birth, or they had infection decades ago and they cleared it, or it's dormant and it might reactivate. And then the surface antibody is for immunity, and the E antigen is for infectivity, and PCR is for obviously a quantitative viral load. And then we start post-exposure prophylaxis ASAP. We test for pregnancy in women of childbearing age, because that really impacts what medications we use. We counsel on side effects, and really about 50% of people experience side effects, mostly nausea and malaise. And then 50% do not complete the full 4-week therapy. For unclear reasons, people with HIV seem to tolerate the medications better than people without HIV. And then HIV test at baseline, 6-12 weeks, and then 6 months, because some people can have a longer incubation period of the virus. All right, I'm going to segue now a little bit toward kind of how these needle stick events happen and some interesting data, at least I found it was interesting, but about 1 in 10 healthcare workers annually sustains a needle stick. This was a pretty landmark article from 2007 out of Hopkins that surveyed 700 surgical residents over 17 institutions across the country. And perhaps this is relatable. I thought this was interesting, but on the left-hand side, they broke it down by PGY year. And you can see that by the end of PGY 1 year, 64%, or the majority of surgical interns, had a needle stick exposure. And the highest risk is actually within the first 6 months of intern year. But by the end of PGY 5 year, 99% of residents had a needle stick exposure. And with the mean number 7.7 by the time they graduated residency. On the right-hand side, you can see that that dark blue bar at the right, PGY 5, is high-risk patients. So those who either have HIV, Hep B, Hep C, or they're an IV drug user and we don't know if they do. And over half of residents, by the end of their surgical training, had received a needle stick exposure from somebody who is high risk. What types of injuries are these? 2/3 of the time, it's the resident themselves who stick themselves during some sort of event, but 1/3 of the time it's someone else, so possibly somebody else in the operative field. Solid bores are more likely than hollow bores, although hollow bores are much higher infectious risk since they can harbor a lot more of the virus. 72% of the time, these occurred in the operating room, and 20% of the time was at the bedside. 52% of the time, this occurred during suturing. In fact, closure of wounds is one of the highest likelihood scenarios of an exposure. And why did they have a needle stick injury? 57% of them said they felt rushed. 15% felt fatigued, and then 20% there was nothing they could do to prevent it. Why didn't these residents report the needle stick? 42% said it takes too much time. 28% said there's no utility. 6% said they did not want to know the results, and then 5% said there's a stigma of having a needle stick exposure. Who was aware of the needle stick exposure? 51% of the time, it's the attending, possibly because they're in the same operative field as the resident. 37% of the time, it's another resident. Strikingly, 13% of the time, it was a significant other. So perhaps the people most at risk for these HIV, Hep B, Hep C acquisitions were the least likely to know about it. What are the factors associated with why they don't report it? Male sex has an odds ratio of 1.6. No involvement of a high-risk patient has an odds ratio of 6. And then the highest factor associated with not reporting of the odds ratio of 20, which is pretty striking, is no knowledge of the injury by anyone else. So if you're alone and you get a needle stick, that's the highest scenario of not reporting. So just some stats. This is some EpiNet data, which is updated. This just highlights that needle sticks is most common among doctors and nurses. It's about 70% of the time. And most of it occurs during suturing with suture needles. The second most common is with disposable syringes. And usually it's the small syringes, the 24 gauge or the insulin needles. For body fluid exposures, it's mostly 80% of these exposures occur to the head region, and most of that is through the eyes. And only 12% in this study actually wear eye protection. As somebody who deals with the COVID eye protection policy, I can tell you nobody wears eye protection here, even when it was mandated. And so this was always a huge risk. You walk in the ED in COVID rooms, nobody has eye protection. And so I understand the burden of it. But I think for surgeons especially, it is critical when there is concern for a splash of any sort. And sometimes you might not know that. But the key, and we'll talk about this later too, is safety glasses are not sufficient because we've had exposures where fluid has come in from the sides. So you need either goggles that go around the sides of the face or a face shield that wraps around. 51% of needle stick exposures occur during use, and the rest is kind of between steps or during disposal. This just shows the type of needle most impacted. Disposable suture needles is 24%, or suture needles are 26%, and disposable syringes are 24%. And again, usually it's that small size. And scalpel is much lower. I think scalpel was at about 5%. And then why do people, and this looked at all of the HIV transmission events from needle stick in the US since they started tracking data. And there's not that many, there's only about 30 or 40, but what were the risk factors for those who ended up converting and having seroconversion? Deeper needle stick injuries as opposed to superficial was the highest risk factor, so 15 times the risk. The procedures devices visibly contaminated with the patient's blood was 6.2 times the risk. Placement of needles in arteries or veins as opposed to somewhere else. And then patients with end-stage AIDS who died within 2 months. And really that implies just these patients had much higher viral burdens. And so the risk of inoculation was much higher. You can see there's a lot of variability in where needle sticks occur. The two most common areas are the left second and third digits. You can see the right ring finger is almost never implicated, and the palms are almost never implicated as well. This study was the same one that found that the first 6 months of intern year are the highest risk. A few other studies that really just confirm what I've that replicated these findings, but 32% occur in the OR. Sharp tip needles are the majority, mostly during the suturing of the muscle and fascia during closure. And 78% are used in devices that don't have safety features, such as suture needles. And then surgeons are the highest risk, and then followed by other people. This was a study that looked at what factors in a case are associated with needle stick. It was really found that there were increased risk in cases with higher patient blood loss, higher numbers of people in the surgical field, which I think is no surprise, and then procedure duration. The longer, the higher the likelihood of risk. And this study also confirmed findings that suture needles were the highest risk on a regression analysis. Similar data to prior, the fellow resident students are usually the highest proportion of events of all staff, followed by the attending physician. And then further down than that is the scrub nurse, the operating room, surgical techs, and the circulators. This was an interesting study that looked at how are our perceptions of needle stick injuries changing over time. So they looked at about 500 surgical medical students and staff in 2003, and then they looked at them again in 2015. And they really asked them, what is your level of concern? What do you think the odds of this are? Have you sustained a needle stick? And about 40% of them said they had an injury at the time of the survey. Similar to prior, over the 50% of the time they felt rushed, or it was careless or accidental. And a third of them had one unreported needle stick. And they didn't really find differences by role here, but I thought this was interesting. The question here was, what do you think the odds are that, you will seroconvert, you will be HIV positive after a needle stick? The most common answer was, I don't know. And then when presented data, most believe that the incidence was actually lower than reality. So their perceptions were that they were less likely to get infected if they did sustain a needle stick. Over the course of the study from 2003, 99% were Hep B vaccinated. When they repeated the survey in 2015, only 78% were Hep B vaccinated. I'm not quite sure why. Here at Yale, I believe we mandate hepatitis B vaccination, or some documentation of immunity prior to starting. In this study, 79% double gloved, 90% of med students double gloved, but only 25% of fellows double gloved. In those who did not, most of them said, I do not feel there's a need. 80% wore eye protection and received Hep B vaccine. This was a study in orthopedic residents that really looked at what types of cases and when do people most likely get the exposures. And then they found that wound closure was the most common time of injury. And then in terms of cases, trauma cases was much more associated with a needle stick than a routine knee or hip arthroplasty. And the greatest importance about what factor, whether or not they ended up reporting it, was the patient disease status, as we mentioned. So if your patient does not have HIV, Hep B, Hep C, they were negative yesterday, that was the factor most associated with not reporting it. And some predisposing factors that we've talked about, but now I'll shift gears a little bit toward what do we do? How do we prevent this? What tools and tricks do we have to really help you guys out? We do a lot of things. So first we evaluate, are there alternatives to sharps? Can we use blunt, suture needles, staples, adhesive, tissue adhesives? We would never recommend a change if there was some impact on patient care. So if certainly it was preferred to use a sharp, that would be certainly allowable. But we work on finding the safest type of sharp. So those with safety devices, a neutral zone in the OR, double gloving, and protective face wear. OSHA has a standard that came out in 1991 that really helps guide us about how we really manage this from an admin level and engineering level, and then work practice controls. So administrative control, example there is we test everybody for Hep B before they start work. And if you're negative, we advocate for the hepatitis B vaccine series before you start as a resident, for instance. Engineering controls is much more what do we do in the OR? Are we doing the safest needles? Do they have safety mechanisms? Is there a sharps bin nearby? And then we'll talk about PPE. But the CDC has something called standard precautions. It used to be called universal precautions, and they've now changed it to what we should be doing for all routine patient care for our careers. And there's, I think, 7 steps. It's perform hand hygiene, use PPE when indicated, perform respiratory hygiene, cough etiquette. That was sort of masking before when you're sick before COVID came about. Ensures safe handling of sharps, abolish safe injection practices, using sterile instruments and devices, and then cleaning and disinfecting surfaces. And then the CDC also has, added layers of safety on top of standard precautions. One type is called transmission-based precautions, which you've seen in the hospital, people on contact, droplet, airborne, but not performing unnecessary procedures or needle use, using needleless devices when you can, doing the safest needles possible, and having a puncture-resistant sharps disposal. So it's recommended to never bend, break, and certainly never to recap a needle if there is not a safety mechanism. Never remove needles from syringes or blades by hand, always dispose in sharps container, and it's recommended to not let the sharps fill more than 75% and really be disposed of when it's about 3/4 full. Studies have shown a lot of injuries occur during disposal. And these are just some examples of mechanisms where these sharps can be closed, which I'm sure you are all familiar with. A little bit about hand hygiene. This is probably one of the most critical steps for infection prevention, but the most overlooked. And this really should be done at multiple different encounters of a patient interaction. But before touching the patient, before putting on gloves, obviously, and I know you have a separate mechanism by which you perform disinfection of the hands prior to going into OR. But really for any patient care, we should be doing hand hygiene before and after. And we've had multiple transmission. Actually, when I started fellowship, I listened to a patient, my first patient I examined, my tie kind of draped over them. And I went to the next room and I didn't think much of it. My tie draped over them too. And then both of the patients, one of them ended up having stenotrophomonas, which is a pretty nasty gram-negative infection. And the second patient got it kind of later in their hospitalization. And I always wondered if it was me, was it my practices? Did I not have my tie appropriate? And so we have multiple cases of events where, somebody has VRE or MRSA, a healthcare worker goes in, they don't wash their hands, and suddenly the next patient in the next room has it, and sometimes can have a devastating complication. You probably have seen us on the wards, our team. We're the ones who kind of monitor, I hate the term hand hygiene police, but they really just audit and track how often are people doing hand hygiene before going into patient rooms. Our average is not good. Very few units get 100% compliance. The average is probably around 60 to 70%. And why people say they don't use the hand rub or wash their hands before going in. A lot of times they say they're carrying something or they didn't think about it and it slipped their mind. But we are required to track this and report it to a lot of our value-based reporting mechanisms like Vizient and Joint Commission. So we do recommend doing this as often as possible, and really would love to emphasize the importance of it. But really it requires 15 to 20 seconds of rubbing your hand together with soap and water, and then rinsing thoroughly, and then patting dry. And then using a towel to turn off the faucet is one of the most missed mechanisms. You guys have seen these on the wards. These are the Purell alcohol-based hand sanitizers. And these are, really a lot better for a lot of reasons, but we can't use them all the time, which I'll talk about shortly. But frequently missed areas of the thumb, between the fingers, the fingertips, and then the wrist as well. But when should we not use Purell? This is always kind of a common question we get. There's several different scenarios. The first is when the hands are visibly soiled or dirty, or they've been in direct contact with blood or body fluids. Then you must use soap and water. And then the other exception are spore-forming organisms. So C. diff and norovirus, both of these form spores that can persist on the environment and are resistant to Purell or alcohol-based hand sanitizer. So these, using the Purell is insufficient. The spores will still be on the hands. So really what we advocate is doing a full soap and water hand wash. And you'll see those red bouffants over the Purells. And that's an indication that you should not use it because that patient has a spore-forming disease of some sort. The other big thing you'll see is instead of contact, the glove and the gown, there'll be this contact plus precaution sign. And that should be a clue to use hand washing instead of the Purell. The other thing we do is we do the orange top bleach instead of the purple top wipes. A lot of people, they use reusable medical equipment, so stethoscopes, vitals machines. When we take our translator, the iPads I've seen too, when those are taken out of the room, the purple top is not sufficient. It has to be the orange top, which is bleach. The purple top is a quaternary ammonium and isopropyl alcohol combination, which is really sufficient for everything else. It's sort of like Lysol. But the orange tops are bleach, which are sodium hypochlorite, which is much more potent against spore-forming organisms. The problem with the orange top is that it degrades equipment. So repeated use over time on your phone, for instance, over time it will degrade. And then finally, I'm going to talk about PPE. But this is a major component of standard precautions and really is there to protect you, the wearer, against an exposure of some sort. And PPE used to be a term nobody knew, but now hopefully it has come to prominence somewhat with COVID. The first thing I'll talk about is recommendations for gloving. So these should be worn when you anticipate contact with blood, saliva, and mucous membranes. These should be removed after patient care, and then hand hygiene should be performed. Even if you have gloves on, you should still be doing hand hygiene, which is the washing the hands or the alcohol-based hand sanitizing Purell rubs before you put on the hands. I myself have had this problem. The problem is the hands are really wet. It's hard to get the gloves on. You have to wait. So it is annoying. But remove gloves that are torn, cut, or punctured, and then wear a new pair of gloves for each patient. Some institutions are gloving institutions, others are not. Here, we are not as much a gloving institution, so we allow contact with the patient with your bare hands if there's not in anticipation of, getting body fluids on them. My two prior institutions were gloving for every single patient interaction, so they had gloves outside each room. The data is really not supportive of either strategy or another. The key is really just performing hand hygiene before going into the room, and then when you come out of the room. Gowns are there to protect the self and clothing from contact with blood and body fluids. These must be tied at the waist and the neck, really to keep it from opening and slipping off the shoulders. And then a surgical mask and an eye protection with solid side shields or face shield protects the mucous membranes of the face. We actually have multiple types of surgical masks that have different fluid ratings. Some are rated highly and more fluid resistant, and others are not. And then clean, reusable face protection between patients. So the eye protection that you guys use for COVID, for instance, can be reused. It's just recommended to wipe it down with a purple wipe or some sort of alcohol wipe after, and then storing it somewhere. I'll say now, the PPE policy has changed where we no longer require reuse or extended use of N95s. Some people would put it on and kind of store it in a paper bag. You might still see that, or they'll put it on and they'll wear it for their whole day. We are in a much better situation with our supply chain than earlier in the pandemic, and we can support single-use respirators. So you go into a room, somebody with COVID, use a respirator, you can discard it and then get a new one for the next patient interaction. That is definitely allowable. We do allow extended use. By all means, feel free to wear the respirator your whole shift if you think you'll be at risk. The real exception to that are conditions where you might by accident contaminate it if you're touching it a lot. So taking it on or off, like if you're dealing with an Mpox or a monkeypox patient, for instance, we would recommend just single use. And then regulated medical waste. You all have seen the Sharps containers. These are designated needle disposal containers, but we also have infectious waste containers for, if there's concern for some sort of infected CSF, pleural, whatever body fluid the patient has. These should be discarded really in a dedicated waste container. And then a few last slides, but there was a Needle Stick Safety and Prevention Act that was passed in 2001. And really with the goal of isolating and removing bloodborne pathogen hazards from the workplace. So a lot of this has been standardized with OSHA. I'll go through a few of the recommendations, but is there an alternative that exists that can eliminate the sharp device entirely? And I know that certainly this is not always the case. Is there an alternative that can eliminate an unsafe feature? So is there a comparable device that has a safety feature? Injury during performance of the procedure where the needle must be exposed for use. Sometimes these are just not preventable, and these could happen. Hollow bore needles are potentially preventable by safer device. Sorry, some of this didn't carry over, but I mentioned before that hollow bore is a higher risk of infectious disease transmission than solid bore because a lot of the viruses can hang out. And so it's really recommended to use solid bore when possible. And then some device characteristics that really have been shown that these are good needle devices. The safety feature is integral to the device. It works passively. The user can tell when the safety feature is activated very easily. It cannot be deactivated, and the device performs reliably and is easy to use. And with this act that was passed, surveillance data over time has shown a pretty big reduction in needle stick exposures. So in the non-surgical setting, they drop by 31%. In the surgical setting, they drop by 6%. Suture needles were the biggest drop at 43%. And then most injuries occur during use or passing of the devices. This was updated in 2020 to include a few extra things. The first is new requirements for the evaluation of engineering controls. I assume somebody in urology it works with Occ Health and us and supply chain really to see what new devices are out there. And are there safer devices with new technology that reduce exposures? It's now recommended that the people who approve these devices are not managers, but they're frontline clinicians who use the device. And that the facility keeps a sharp logs of injuries that occur, which we do. Are teams that work together better than creating new teams every day? So they looked at dedicated teams, essentially greater team stability of people who always do the case with the same people. And not surprisingly, this lowers the risk. The impact was felt most on devices other than suture needles for kind of unclear reasons, but perhaps if you found your core operative team, that over time you would learn each other's practices, and somebody's right-handed versus left-handed, and so a lot of that can really help out. So this study showed association between team stability and risk of exposure to suture needle was not significant, but all other devices besides the suture needle was. And then in closing, what can you do? So avoid use of needles when alternatives are available. Get involved, if you can, with urology about selecting and evaluating the safety devices, and use the safety devices. Avoid recapping needles at all times. Plan safe handling, disposal of sharps before any procedure. Dispose of used needle devices promptly. Report all sharps-related injuries, and we prefer to know about it even if the patient does not have a bloodborne pathogen. It's quite rare where somebody has HIV, Hep B, Hep C testing the day of or the day before the OR. Report observed hazards from sharps, and then continue to participate in training. And I think this should qualify for your annual training. And then our team focuses a lot on infection prevention practices, and then what we can do to prevent HIV, Hep B, Hep C. And we obviously don't have vaccines for HIV and Hep C, but Hep B certainly we do. And just as a reminder, the largest percentage of all sharp injuries occur in the OR, with the greatest numbers amongst physicians. And so infection prevention and control is really everyone's responsibility, and obviously it starts with you. And then I'm going to close with 2 slides just as a reminder. What do you do if you get a needle stick? So recognize the exposure and remove yourself from the field in a safe manner. Clean the exposure site with soap and water. Notify the supervisor, notify occupational health, and then we will perform a risk assessment to see what the risk is. Do you need to go on any medications? Are you vaccinated or not vaccinated? And then test and treat if indicated, and then counsel and follow up. This is the Yale employee health number. which I believe covers all delivery networks, so they should be able to route you to the right one. But this should be in, I believe you can also find this in Mobile Heartbeat. And then I know that we in infection prevention are also available on Mobile Heartbeat 24/7. So I'll close. Please stay safe out there.
With the exposure, who pays for your testing, and does the patient pay for their own testing? And is that a barrier to someone agreeing to testing?
So the hospital covers 100% of the cost for all of it. So we cover the patient, we basically talk with patient billing and we say, hey, don't bill them for this. And the staff members are fully absolved from this. I don't know actually if it goes through insurance or not, but my understanding is that we cover really all of this. So it should not, you guys should not be covering this at all. And if that happens, certainly let me know. Yes.
Just curious, for a patient that ends up like dying and there's no labs for like a trauma patient, for example, and there is a exposure, like what's usually the protocol for that? It was very confusing.
Yeah, that's a good question. And unfortunately it happens a good amount. Most people, we don't know their status. And so, we saw this with COVID, for instance, people coming as traumas, they don't get tested, we never know. With needle stick, what we do is we essentially treat them as if they're positive to be safe. So if you get a needle stick, we'd still recommend to get tested if the trauma patient ends up dying. Obviously, if there's any blood, we hold the blood work for, I believe, I forgot how long it is, but it's no more than 3 days for sure. So if available, we'll always do retroactive HIV, Hep B, Hep C testing. We have had a number of cases, we had 2 unfortunate cases recently of fentanyl syringe reuse in moderate sedation cases where patients, fentanyl was used on one patient and they used the same syringe to inject it in another patient. And in both cases, unfortunately, the source patients refused to get tested. And so those patients who end up getting through the IV, we end up testing them at the moment that we detected the exposure, with the thought being that we should know if somebody is infected within days. And then we do a counseling session on whether or not we should start PEP. And some people say, I want to start no matter what, give me the drugs. Other people say, I don't, I want to wait and see. And certainly, the risk, if you don't know what happened and you get a needle stick exposure, the odds are the patient does not have anything. But 1%, about 1 to 2% out of they might. And so we definitely want to know about it. And then if you think somebody has, my example at the beginning, somebody has active Hep B, Hep C, HIV, and you get a needle stick, the odds are still in your favor that nothing will happen, certainly. But transmission events do occur. And so we take this very seriously. We've seen a few other instances, not here at Yale, but of healthcare worker to patient events. And so there was one surgeon, I think in Florida, who ended up giving Hep C to 5 or 6 of his patients. Again, we do a baseline assessment when you get here, check your Hep B status. But if we don't know, we're just going to treat everything as if we don't know. And we prefer being safe than sorry.